Good afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on improving mental health care for Black youth, lessons from qualitative research. My name is Dr. Carl Cabasel. I am a public health physician at Public Health Ontario, and I have the pleasure of moderating today's session. Now, before we begin, I'd like to start with a land acknowledgement. My colleagues, as we gather here today, we find ourselves in the month of June, a month that holds great significance as National Indigenous History Month, a time to honor and recognize the rich heritage and enduring contributions of Indigenous peoples. Now, National Indigenous History Month urges us to honor the land we gather on today, recognizing the stewardship of the Indigenous peoples who have cared for it for millennia. And it's an opportunity to learn from their wisdom, culture, and spirituality, acknowledging their ongoing struggles for self-determination and for justice. In the field of public health, we have a special responsibility to support Indigenous communities. We must ensure that our services and programs are inclusive, culturally sensitive, and responsive to the unique challenges faced by Indigenous peoples. And it must be our commitment to foster an environment where everyone feels seen, heard, and supported. So let us take a moment to reflect individually on the journey we are on as allies, advocates, and change makers. Let us rededicate ourselves to the values of equity, compassion, and respect that bind us together as a community. Thank you. Okay, so now before we begin the formal presentation, I will mention a few housekeeping items. If you require CME credits, please email capacity building, that's all one word together, capacity building at oahpp.ca. And I'd like to state for the record that as the moderator of this session, I have no conflicts of interest to report, but in the spirit of full disclosure, our special guest today works at the Center for Addiction and Mental Health, and so do I. Now, it is now my great pleasure to present our speaker for today's event, Dr. Amy Gajaria. Dr. Amy Gajaria is an associate scientist in the Margaret and Wallace McCain Center for Child, Youth, and Family Mental Health, and she's a psychiatrist at the Center for Addiction and Mental Health, or CAMH. She is also an assistant professor in the Department of Psychiatry at the University of Toronto. Dr. Gajaria completed her postgraduate training in psychiatry and child and adolescent psychiatry at the University of Toronto. She has a specific interest in supporting the needs of racialized young people and was a recipient of a public psychiatry fellowship from the American Psychiatric Association. Amy, welcome.
Thank you so much, Carl, and I'm really thrilled to be here with everyone today. Thank you for taking time out of your day to listen to some findings from our research project. I just joined Blue Sky, so I have Blue Sky on there, some contact information on there, so please don't hesitate to reach out if needed. And I think this is just a disclaimer that we had already. There's a couple of things to know just in terms of funding for the project. These kinds of projects take a village, and so we had a lot of funding support from these places, and I also get some salary support for the research work that I do. So today we're going to talk a little bit about a research project that we did looking at barriers, facilitators, challenges for Black youth in accessing tertiary level services with a specific focus on things like hospitals and specialty care areas. We'll talk a little bit about what some of the unique challenges are. We'll think a little bit together about how do we, design research and think about research in a way that feels good and appropriate to underserved populations, and then also incorporate some conversations about knowledge translation and how that can be built into research design. And some folks here may know and some may not. Black youth, unfortunately, are not currently well served by our mental health system. I'm very privileged to work with a program called SAPACY, which is the Substance Abuse Program for African, Canadian, and Caribbean youth. And I've been doing that clinically for about 5 years. And certainly what I see in the literature is very much what I see in my clinical practice, is that Black youth have a lot of mental health needs, often due to systemic racism, structural issues, things that have been going on for generations. Unfortunately, and as is the case for much of children's mental health, Despite the high mental health needs, there's lower mental health access and a longer wait to access services. And across the children's mental health sector, we know that complex and hard to serve youth, unfortunately, paradoxically get the least amount of service and the least amount of care. That's even more exacerbated when you have marginalization, and that is certainly the case for Black youth. So we acknowledge that yes, there's barriers and challenges across the children's mental health system, but that's even more amplified for Black youth. And unfortunately, still to this day, we're seeing Black youth access care more through emergency or forensic pathways. And for those of you who aren't in psychiatry, forensic means through the criminal justice system, either somebody has been incarcerated or they've been incarcerated and found not criminally responsible by reason of mental disorder, or they're brought in by police to the emergency room. That's much more frequently the way that youth actually get access to care. They're underrepresented in voluntary and outpatient settings. And if they do get through the door, their experiences are quite negative. So if you look at qualitative studies, surveys, that kind of thing, a lot of youth are describing that if they do get through the door, mental health care is not meeting their needs, and it's not the kind of care that they need, in which they're felt to be treated as individuals and people deserving of care and treatment. And unfortunately, the situation of mental health in Black youth is not getting better. It continues to worsen. Suicide rates had typically been lower in Black populations, but unfortunately now they're rising. And they're, in some cases, in some populations, completed suicide is overtaking that of the general population. We are also seeing higher rates of opiate overdose in Black youth, which again had not really been as much of an issue a few years ago, but unfortunately now is also rising, which is contributing to mortality and morbidity in this population. And unfortunately, and we have another paper that just came out in the Canadian Journal of Psychiatry demonstrating this kind of in the Canadian context. But in the American context, we have a large amount of data that shows that as mental health providers, we are misdiagnosing racialized people. So we commonly overdiagnose externalizing things such as psychosis, substance use problems, conduct disorder, oppositional defiant disorder, and very commonly misdiagnose, underdiagnose, or don't diagnose at all internalizing disorders and PTSD. And then there's also a criminalization of people who are Black and who are racialized in terms of how they're seen with the same behavior as a white person. So even though substance use rates are quite comparable by race in Canada, with the exception of Indigenous populations, Black people are more likely to be criminalized for the same presentation of substance use or mental health concerns on what we assume is the basis of the color of their skin. If you control for a lot of other variables, that difference still kind of stays out. And so we're seeing criminalization of mental health concerns as well, and that persists in Canada. And what I always like to say in the work that I do is that these disparities are not inherent to a person. They're not inherent to being Black. They're not inherent to a culture. Rather, they are inherent to systemic and structural racism. And that includes both within the healthcare system and within our system as a whole. So as a system as a whole, we have put a number of barriers in place that continue to persist. And it is those structural and social determinants that really are causing these mental health disparities. It's not something about the culture of the individual. What we also know is that members of the Black community tell us that they're quite aware of racism within medical settings. They're also exquisitely aware of the history of racism in medical education, clinical care, and research. And that impacts uptake of it being involvement in research projects, being really tentative or unsure about clinical services, and about engaging within the system. And that, of course, leads to mistrust of research and traditional clinical settings as a result. And I would argue that the intervention there is not just tell people to trust you or just get people into services. That's commonly what I'm asked. Oh, how do you just get people through the door? But I don't think we should just be doing that, because then you just recreate harm. What you have to do is create a system or a service that actually meets the needs of people, that actually is a safe environment, and then they're going to want to walk through the door and you're going to want to tell them about the changes you've made. But simply telling people to come when you haven't created a safe environment doesn't solve this problem. And so consistent with that background, the work that I do, and I tend to come from, I'm a qualitative researcher, so I'll tell you my positionality, my theoretical frame, and that is that I come from a school of critical theory, and then specifically critical race theory. And within critical race theory and critical theory, what we are interested in is understanding what are these things, these structures, these systems that we might consider to be the norm or invisible, but are driving disparities in experience and in access and in healthcare. And how can we make visible what we've caused to be invisible and therefore action upon it? So it is hard to action upon these drivers of health if we don't really understand them. And within a critical theory perspective, we're really kind of making that visible and understanding where we can come in. And then, as I mentioned, foundational to critical race theory is that racism exists, structural racism exists, systemic racism exists, and we need to look at how that's operating in a really kind of clear, planful way, not kind of hoping it'll emerge or saying everyone's colorblind or everyone's the same. We are specifically looking at this from a lens of power, privilege, and structural racism. And within that as well is the idea that communities have their own solutions, wisdom, strength, and guidance to solving their own difficulties. And that includes health disparities. And that I really believe in the idea that knowledge is here to be shared and not withheld. And for me, that really speaks to working within community, working in solidarity, working as a person who is racialized and raised as a racialized person, in which community, strength, and wisdom is how we move forward, rather than it being like this individual person who sort of leads everything and moves you forward that and holds the wisdom. To me, that is not the kind of context in which we should be moving health systems forward. And so the research question, what are the barriers and facilitators for Black youth in accessing mental health care in hospitals and tertiary care settings? We did a qualitative study design and we gathered data in a couple of different ways. So we looked at individual interviews with key stakeholders across multiple sectors. And what was of interest there was not to talk to people within the health system. So we specifically actually did not interview people within the health system because we wanted to know what was happening to the kids that are not coming through the door. So we talked to people in the criminal justice system, children's aid, Toronto Public Health, like the home visiting programs, grassroots organizations, people who would interface with Black youth and see kind of who are the kids that are not coming, because we want to hear from those. We also spoke to Black youth through focus groups and then to caregivers of Black youth. And then we also heard from our community partner, which I'll speak about in a second, that an area that is really poorly served in the Greater Toronto Area is Black Francophone youth. And I hadn't thought of that within the GTA. I thought about it in Ontario, but not so much in the GTA. But we learned that that was a very specifically marginalized and underserved community. And so we reached out to a stakeholder and a community caregiver who could speak to kind of some of the specific challenges for Francophone Black youth. And then all of it was about self-identification because, again, we didn't want only people who had accessed care or had a formal diagnosis because we know that's a barrier. So youth could self-identify as having had difficulties with their mental health as a member of the Black community. Caregivers similarly were self-identifying. They did not have to be Black themselves, but they had to have experience caring for a Black youth. And then again, the stakeholders were across the system. This was designed from the start as a partnership with CAFCAN, which is Caribbean African Social Services. That is like from the beginning, from funding all the way through. They were meaningfully involved in generating the protocol, in generating the research question, in the study design, in the budgeting, in the knowledge translation. So we really did our best to partner with them and to understand from their perspective, what did the community need? Why was this important to them? How would it be meaningful to folks? How would we give it back? And that was kind of right from the start. We also had youth engagement experts, so youth with lived experience, again, who were involved from the beginning, from study design, design of questions. They actually came into the interviews. So our interviews, especially with youth, although with everybody, but specifically with youth, had a youth with lived experience in the room, and all of our interviewers were Black youth as well, so that it would kind of look at considering that power dynamic and trying to allow people to share some more information. And again, our youth engagement folks were from the beginning all the way to the end, so involved in every aspect of research design, data analysis, and knowledge translation in order to really try to have this be meaningful engagement. And I am not Black. but the team was majority Black. So I think it was 80%, if not more, of the team was Black. We specifically hired a research assistant to do the interviews who was Black and made sure that our youth engagement folks were also Black. And so people either were Black or they had had meaningful experiences with Black youth through frontline clinical work. And I mentioned this a little bit, but this is basically just the theoretical frame that I alluded to before. And then the other important part that I hadn't mentioned before was within critical race theory, as some of you may know, an important and critical part of that is the idea of counter narratives. So the idea is there's one story that's told in the mainstream about certain populations, about racialized people, but through research, you can elicit counter narratives. What's the other side of the story? What does the community want to say? How do people want to explain their lived experience? And you elicit this idea of a different story, a counter story that speaks back against what's there in the dominant discourse. This is our team. It was a big team. It was a fabulous team. We had a kind of some trainees in there who were doing graduate school, their master's education, their residency training, as well as folks both in Toronto, and then we have one of our lovely people who's now in Calgary. And so, as I kind of mentioned at the beginning, what we found was consistent with what we know to be in the literature, and that is that existing mental health systems issues are exacerbated for Black youth. So there's a lack of representation within mental health workers that enhances mistrust, reduces care seeking, amplifies stigma, and is linked to more negative experiences of mental health care. So there's implicit and explicit racism within the system and within the providers. And that racism makes it more difficult for Black youth to access care through non-aversive pathways. So part of why they're not coming through the door is they're aware of racism, they're aware of the racism that's systemic and then in individual providers, and that makes them not want to interact with services. And they're just generally worried that they'll be dismissed. So they generally fear that they'll come through the door, they'll say, I'm struggling, and people will just dismiss their difficulties and say, that's not really a big problem. Oh, maybe you should just do something else. And that's something that I certainly hear clinically as well. And this is something that gets handed down. So you'll see the quote, my mom used to tell me, don't go to CAMH. They have a file on you. And if someone looks you up, they can find your file. And it was just one of those things where it's like, why do I want to put that? Why do I want to leave that red ink on my file? So some of this information is also handed down from people who've had experiences with the system. And then another thing that folks talk about is the idea that they're seen as Black and then a patient. So they don't get the benefit of just being a patient, of just being like everybody else. They experience the healthcare system and healthcare providers as labeling the color of their skin, seeing their Blackness before they see their mental health needs or before they really treat them as a patient. And that is really due to the biases and misperceptions that caregivers have that really impacts the experiences of youth, including their access and experiences of care. And they talked about a lot of things. This was from youth, from stakeholders, from caregivers, that kind of the first assumption is that there would be assumptions of criminality or bad intent. And that people are here, because they're trying to cheat the system, because they're involved with the criminal justice system. They also talked a lot about providers over-relying on substance use as an explanation for distress or symptoms. And there was an assumption that, oh, this is because you're using substances. It's not because you have like a quote unquote real mental health difficulty. And then there was also this idea of focusing on tropes. So going to stereotypes, ways that people understand Black people, especially mental health providers, that wasn't actually about the specific person in front of them, and often made people feel like they were just a stereotype, they were just fitting into a box, and they weren't being seen as like a specific person. And then also not considering systemic issues and explanations, and assuming that any adverse outcome is linked specifically to culture or Blackness. So if people are not coming, if they're not kind of coming through their doors or not accessing care, it's because we have to educate people or teach them, or this culture doesn't value mental health. These are all things that I've heard clinically. They're not outrageous, they're said all the time, and no kind of systemic or structural lens on the reasons why this is happening. And this is the quote, people see you as Black before they see you as patient. And it's one of those things where people expect you to have all this trauma because you're Black. I don't know what the equivalent, and we have all these traumas. We come from these Black neighborhoods. People expect the Black experience to be rough, and yet they don't provide the help in these Black areas. And then people may sometimes say, oh, yes, there's been a challenging experience for Black youth accessing the mental health system. That's something that we want to be aware of. However, they don't actually fully understand the truly harmful and negative experiences and really how aversive and how negative these experiences are for Black youth. They don't understand that these can really kind of change the content of someone's life and really change the whole trajectory of a young person's life. Because remember, we're talking about young people, children, adolescents, and youth, where whom some of these experiences can really change everything about their lives going forward. And one of them say, all I'm saying is you can't ignore the compounding effect of what these things do to people and do like their life trajectory. Part of the impact, is this very aversive pathway, but I'm trying to be clear that it's not just the aversive pathway. It's that there are certain experiences that people face in going through these aversive pathways that fundamentally change their lives. And I think, again, they're saying that mental health providers are not understanding the depth of this experience. And when it comes to caregivers, there's this duality of both dismissing and then also seeing caregivers as intrusive or problematic. So the mental health system and care providers don't really acknowledge the fact that many kids are coming through the door repeatedly. They're trying to access services. They're saying, I need help. They're experiencing being dismissed or minimized. They're not being appropriately diagnosed. So instead of sort of acknowledging all of those systemic factors and the fact that we really need to change our system, what the mental health system says, and again, these are things I've heard again in my practice and my training, they'll say, oh, it's just that people don't care for their loved ones. We need to teach them about mental health. If they just knew more, the problem would be solved, without actually acknowledging the ways in which people have presented multiple times to try to get care and been turned away. And this sets up a white savior system in which there are caregivers, families, and communities that are in need of saving. And that, really is paired with the idea of structural abandonment. So if you underfund, understaff, and don't meet the needs of a population at a system level, not just in health, but across multiple sectors, you create the perfect storm for white saviorism in which people are not getting what they need, their needs are not being met. We must go in and individually save them or teach them how to do things better, instead of acknowledging that the ways in which these things have been designed are actually creating these disparities in outcomes. And this is used as a way of justifying the disempowerment and dismissal of Black caregivers, and also marginalizing their advocacy for their loved ones' care. So often being, seen as problematic, as troublesome, as difficult, as needing to be excluded from care, as just not getting it, and we're the system that's there to help you and save you. But that's kind of happening among the background of all of these other forces. And then there's a burden on Black healthcare workers as well. So because the system is not really serving the needs of youth, because it's so fragmented, families, youth, and caregivers will talk about needing this informal connect. They need to know the person that will get them in the system because the formal pathways don't work. And so they work their informal networks and personal connections, but that's an additional barrier and burden on Black mental health workers, because not only are they in the system, they're trying to serve youth, they then are trying to field all these things from the community, but then they also have a lot of their own vicarious trauma, race-based trauma and otherwise, that they then have to navigate. And then often they're also called on to do other things like anti-racism training, education, teaching about cultural competence, over and over and over again. And that is part of the issue with staffing and retention of Black mental health care workers. And they say, we are so impacted by the system and the systems that surround them, but they cannot be responsible for doing the work. That re-traumatization for our Black leaders and also our social workers and social services workers, it's extremely traumatizing to always be the person doing that work and expected to do the work. And there's that idea of come and tell your story of your trauma narrative or how difficult it's been for you, but we won't necessarily compensate you appropriately, recognize your achievements, make sure you're being given the things you need to succeed. It's just more and more burden. And then the question is, why aren't people staying without kind of addressing these issues? And then thinking about intersectionality, there's a real need to specifically support the needs of Black 2S LGBTQIA+ youth in a way that is both culturally affirming and affirming of their gender and sexual identity. These services are really lacking even in Toronto, where we have a huge Black population, a huge queer population. Black youth are still saying, if I'm part of the LGBT community, I don't feel safe. I don't have anywhere to go. I go to the spaces that are for LGBTQ youth. There's no one who's of color there. There's no one who's Black there. There's no one who's from my neighborhood, specifically for kids from like Jane Finch, Scarborough, Rexdale. Like, I can't relate to these people. But if they're within their community, they're closeted and they don't feel safe kind of being out. And then there's also the multiple marginalization. So the more ways in which you are discriminated against at a structural level, there's a multiplicity of impact on your access to mental health care, your mental health outcomes, by virtue of just having that much stress. If you think about a minority stress model, people who have multiple axes on that will have worse health and mental health outcomes. And then we also heard that we're not doing well by our Black youth with psychosis. That there are Black youth that do have diagnoses of schizophrenia, substance-induced psychosis. Those are the people that are super overrepresented in the forensic system and the criminal justice system. For example, when I'm on call overnight, I cover the forensic units at CAMH, which are for people that are under the Ontario Review Board, have been found not criminally responsible. It is a huge, disproportionately Black population with psychosis. And we are not doing that right. We really need, and we're hearing from people, is that they really want culturally sensitive, affirming, and community-led and engaged services for Black youth that experience psychosis. There's an outreach component, there's a family-based component, and there's a way to do that in order to avoid having young people really be overrepresented in forensic and criminal justice systems. And then there is stigma, and it's not to say that there is no stigma and we should ignore that. It's just to contextualize it within all the other factors. And that to understand that, of course, stigma for caregivers is influenced by their own lived experience and their treatment within the health system. And youth are saying, well, we have a different understanding and attitude towards mental health care. We're a little bit more willing to access. We feel a little bit more like we want to go to these places. But sometimes our parents are reluctant. They tell us to pray. They tell us to do other things. They don't really get it. They're really nervous about the health system. And sometimes that prevents us from accessing care. And they said, can you tell them some more stuff about mental health? Can you go out and talk to them and tell them about mental health services and where they might be able to access it for us? But we want to make sure you do that in a way that's anti-racist and culturally affirming. So in summary, youth told us a lot about what they wanted from care. They told us that youth-friendly and culturally affirming care is being authentic, it's being human, it's being true. They say, talk to me on the level. Don't pretend to be something you're not. I always tell residents, don't try to pretend to be cool because it's not going to go well. Just be yourself, be authentic, and connect to someone on the human level. We hear this over and over and over again. The food is terrible. I'm not staying there if the food is terrible. There's no seasoning. There's no spice. I don't want to eat it. So understanding that food is such an important part of so many of our cultures. It's how we show care. It's how we show welcoming. It's how we show that we're interested in people. And if you come to any event for a person of color and there's no food, I've never been to one, so it's something that's important that we think about in our services. Also talking about spaces that are youth and Black friendly, that they're beautiful, that they're not kind of just the cheapest thing you can find. And I know we're always trying to make do with that, but youth are saying, let's make a space that's really beautiful, that we want to be in, that we feel good in being, and that we feel welcomed in. And understand the whole person and their whole experience. So really be deeply curious. What is their story? Who are they? How do we understand them rather than relying on stereotypes or assumptions? And if you don't know, then spend some time getting to know more things about Black youth, Black culture, not in a way so you can pretend that you know, but just in a way that you can kind of be more curious and be more interested. Really, where possible, it's not always possible in tertiary care settings, especially for people that have significant mental health difficulties, but where possible at all, reduce or avoid or separate connections to police or security. Something that comes up, actually it's very specific, but it comes up over and over again, is if you sit there and write notes as a clinician, youth will experience that as being in trouble, being surveilled. They actually don't want you to just sit with your head down and write notes. They want you to make eye contact with them and have it be more of a conversation. They also want to see diversity of the Black community in the GTA within services. So again, the idea that one Black person is not representative of the Black community within the GTA, or Ontario, wherever you're working, there's a huge diversity within the community, Caribbean, African, Francophone, Anglophone, queer, not queer. There's so many different kinds of experiences. And then really, really people want to see psychotherapy, trauma treatment, and trauma-informed care. They're not necessarily completely against medications, but if the medication feels like the only option, that can feel dismissive to folks, and that there really is a need for psychotherapy. And in Canada, we know that unfortunately in Ontario, largely it's easier to access psychotherapy and specifically trauma therapy if you can afford to pay for it out of pocket. But if there's disproportionate rates of poverty and difficulty accessing services for Black youth, then you can see that the access to psychotherapy and trauma-informed care is really limited for these populations compared to the general population. And youth really want you to welcome them into care. They want you to feel valued and wanted. It can't just be like, okay, well, the door is open. We have OHIP, again, things that I've heard. Because there's so much mistrust and because there's been so many negative experiences, you kind of have to really actively go into it. You have to actively undo that mistrust and fear that's there. Caregivers want to be involved and informed and updated where possible. That's always attention in working with children, youth, and families, but negotiating kind of how you can do that based on, the relationship with the youth and kind of being flexible in your consent. So often I'll say, can I share this, but not this? And I'll kind of really understand what I can do to involve the caregiver. But of course, if the youth doesn't want it, the youth doesn't want it. But then also to understand the lived reality of being a caregiver who experiences marginalization while also doing the job of supporting a loved one with mental health difficulties, that it takes a lot for them to also walk through the door. And we have to kind of think about what their experience has been like with thinking about mental health systems, with accessing them, with dealing with the system. And so when we're dealing with a caregiver, we also have to apply some of those same principles. And caregivers also say we really want to know how to navigate the system better. We want to know how to advocate for our youth. What's the language we should do? How do we advocate for care effectively? How do we do that in a way that makes us heard versus kind of dismissed or disregarded? They also just want to know that their loved ones are being cared for as a person who is a whole person with a whole identity. And they just want to feel that they're safe when they're in mental health care settings. And when they do ask, like, I really want my young person admitted. I really think they need to be in a hospital. If they trust you, they will start advocating for things like that. And then something that came up a lot was to understand colloquialisms or common expressions that are cultural. My mom says they're going to kill me. Maybe just ask a question. What do you mean by that? Tell me a bit more about what you understand. Give me the context, give me the story, instead of immediately jumping to children's aid or reporting or intervening without understanding what does this person mean when they're saying that? Or if they say, I just want to kill that person, they don't necessarily actually mean that. It's just part of our clinical assessment. And then professionals want mental health providers to integrate structural supports into mental health services. They really talk about the idea that ideal mental health services will be co-located with other things that promote the mental health and well-being from a structural perspective. So thinking about, well, if you come in through the door, can you also deal with your ODSP application? Can you talk about income support? Is there an employment worker? Is there some way to deal with the idea of food insecurity? Do you have a green fridge with fruits and vegetables? Is there someone who's there who's a housing worker if you're facing eviction or you need to know your rights? Of course, we can send folks outside. It's just another barrier and another relationship folks have to build. So as much as possible, if that's within one space, people tend to find that more helpful. And then is there collaboration with organizations across the system to support and improve service navigation for youth? Are you just sitting there as a standalone, or do you really integrate with other services so that you can leverage relationships, do warm handovers, and really help deal with that fragmented system? And then when it comes to Black mental health workers, again, not just hiring and assuming that hiring is where you stop, It's not just about hiring, but it's also about retention. So if you bring somebody in, are you aware of some of the things that might have come behind them? Are you aware of the trauma they carry with them? Are you aware of the idea of like racism and how it might function for them in their day-to-day experience? And how do you actually action that, operationalize that, and actively and enthusiastically support staff so that they stay within the organization? Versus which happens to lots of racialized people, specifically for Black people. And I think we see some stuff in the literature specifically about Black women getting really relegated to the side and being labeled as problem or troublesome when they're trying to advocate for the needs of their community. And the youth, oh, I missed one quotation mark. So we presented these findings to our youth, some of our youth engagement folks, and we have a Black Youth Advisory Panel at CAMH. And they said, so all this info for what? Like, great. You just did this study. You told us the stuff. It's really painful. We know it. So, like, what are you going to do with it? And so we talked to them about what they'd like to see. And we also had built in a knowledge translation component to the study. So when they told us all this information for what was important to them to hear was that we intended to take this information and pass it on to other people, not just Black youth, not just to Black communities, but to take it to people who have influence on policy, people like yourself who might be doing public health interventions, people in government. They really wanted to say, okay, we'll take this information and share it to the people that make some of these decisions, because then things will actually change. And then we believe in why we're doing research. Otherwise, it just feels like re-traumatizing communities over and over again. So we took the same findings, kind of in different language. We did a community outreach session in May, and I'm so proud of this. I love this. I think it was just a beautiful couple of days. So we did a 3-hour session. It was out in Scarborough, a really beautiful place, great food. There was jerk fish that people were very into. And we presented some of our findings to young people, and we asked them, what do you think? And what would you want from services if they were better for Black youth? And I like this because very emblematic of youth. There's some stuff in there that's a bit silly, and then there's stuff that like is really helpful, but they tell you, racism, circumstances, violence, thinking about gay youth advocacy. These are the kind of things that they presented as what they thought was important. And then what we did after that is we had them have an art session where we invited in a community organization, Art and Health, and also Wanasa. There were two sessions, and youth then had an opportunity to like express their emotions, use art and nonverbal stuff to get out their feelings and their emotions. I should say all young people in these slides have all given consent for their photos to be taken and used in these kinds of ways. And so they came in and they did that. And then in parallel, we spoke to their caregivers, and it was really lovely. We actually had only allocated an hour to kind of address what people had said in the research study, which was we want caregivers to hear more about mental health, but in a way that speaks to them. So we had members of the SAPACY team. We have our incoming psychiatrist, Dr. Osagi, our nurse, Shalon Rogers, and then one of our social workers, all Black people. Just take all the questions. Most of the heat went to Josiah about medications and diagnoses and all of these things, but it was an open conversation, and we'd said, okay, you have an hour, but people wanted to talk for much longer. So we just changed the day and we had them ask questions for 2 hours, and then we've had to cut them off. And then everyone came together and they shared together. Youth and caregivers shared together what they had learned, what they thought was valuable. And it was just a really lovely moment where people said, look at all this brilliance in this room. Look at this opportunity for us to get together. We loved that our youth were able to talk about mental health, but also use art and different modalities. And we really valued the opportunity to like switch that power and ask you questions and get some more information, but be able to like really challenge you. So that was that. And so just kind of in the last couple of minutes before we hand over for some questions, is some of the things that we learned from this was that knowledge generation is collaborative and can be collaborative. It can be used to support bridges between community and institutions, but you really have to think about that from the start, from your design, from your engagement. You have to think about anti-Black racism really explicitly, and then kind of be willing to navigate and change and modify and have conversations with people throughout the process. The nothing about us without us, again, trying to make sure as much as possible that there's representation. And part of kind of why I'm here today is I work with the team to kind of say, I want your expertise, I want your guidance, I want to make sure I'm hearing from you. Part of my role as an ally is also to then take that and do some of the heavy lifting and take it back to folks and get the funding and do some of that work so that it's not all on people from the community, but that we're hearing their words and their message and bringing it forward. And I truly feel this to be true in my clinical work and just in research in general. The best thing about qualitative research is you read these like deep narratives. People are trusting you with their vulnerability, with their stories, with their experiences. And it's really a true privilege. And I feel a responsibility to treat that with respect and to really give that forward and to honor what people want done with that information. And we uh, we're not perfect, not like fixing mistrust with research, but kind of the idea that we can do research differently. We can do it collaboratively. We can do it with community. We can hear what they want, and we can try to take some steps forward to undoing some of that previous extractive and mistrusting relationship with communities. And that is it from my end. Again, there's some ways to contact me, and I will hand it back to Carl for the question and answer. Thank you so much for your time.
And thank you, Amy, for your fantastic presentation. And thank you, everyone, for engaging with us. At this time, we'll move into our Q&A segment of the event and to address some of the questions from you, the audience. Quick note to everyone, please continue to enter your questions into the Q&A pod. You'll see at the bottom of your Zoom the little Q&A with the speech bubble symbols. Go ahead and click on that and put your questions in. I'm seeing questions coming in already, so I think we'll just jump right into them. And let's begin with our first question. Why would there be so much psychosis among Black youth? So in your presentation, Amy, you mentioned that you tend to see quite a bit of it. Is there it can be hard to, I guess, attribute a cause per se to psychosis, but what are some of the theories around the amount of psychosis you're seeing in Black communities among youth?
So I think there is there's a little bit of a bump in the overall base rate for psychosis within Black populations. But what is really overrepresented is the representation in the criminal pathways. So what I meant there was if I'm in like a jail setting or in a setting which people have been found to be in violation of the law, there is more representation of Black people with psychosis in those settings. But in terms of the things that kind of bump that base rate up a little bit, a couple of theories are out there. One is about migration. So there's some research, I think it's Kwame McKenzie, who does work looking at the stress of migration. So there's both the stress of migration for the first generation, but then also typically we see second generation immigrants having worse mental health than first generation. And there's some thought that that's about the stress of migration, the stresses of like all that discrimination, but then also the kind of balancing the acculturation. Like that's a lot of cognitive load on somebody. And then some of the other things people talk about is just the amount of stress there is for people who've experienced repeated marginalization and discrimination. If we think about, again, minority stress model, your brain can only handle so much. And so if you throw enough stress at someone, you likely will see worse mental health outcomes. There's probably also something about overdiagnosis of psychosis when it's actually trauma, because with PTSD, with complex trauma, of which race-based trauma is also something. People can have psychotic experiences that are not necessarily like schizophrenia or something like that, but the trauma piece can be missed, especially if people are not curious. And then we do see, and again, I don't know the actual data on this, but there is Black youth in my substance use practice. Marijuana is a substance that people are kind of more inclined towards versus some other substances. And that because the THC concentration has gone up so significantly in the potency, when I see people using like 90% THC, those vape oils, those kind of things, those are very dangerous in terms of psychosis risk. And that's something that I see for Black folks in Toronto, but also something I see for Indigenous people when I work in the North.
Okay. And I think something I heard you say in your presentation was that often with Black patients and Black youth, there's a assumptions are made. There's a quick jump to what have you. So you mentioned just now that a person who's experiencing trauma might be misdiagnosed with psychosis, but I'm sure that the reverse could also be true. That someone who actually has psychosis, it's downplayed because, oh, it must be substance use. Oh, it must be something else. So I guess the key here for those clinicians out there is to really pay attention and don't make assumptions and treat your patient as you would any other, as a complex human being. Simple.
Yeah, I think that complexity really gets flattened out, and that's something that we heard when people were saying that Black them patient is that complexity is not seen in the same way in Black people. And that really leads to some of these challenges, either misdiagnosing as psychosis or missing the psychosis. Because people will say there was this sort of shift in the pendulum where people would be like, oh, well, they talk about being followed by police, but they're Black, so they can't have psychosis. And it was like, well, there's still a nuance there. Like you still have to assess it and find out the nature and severity of what's going on and understand that within someone's like lived experience.
Right. And then the other piece I just want to quickly pick up on was the idea of that allostatic load, that racism and stress leads to physical changes. That's been shown in the evidence. But I guess maybe we don't think of it so much in terms of mental health, that stresses have that effect potentially on mental health as well. So thank you for pointing that out. Let's go. We have quite a few questions, so let's move to the next one. What resourcing should communities prioritize, i.e., where should funding be directed to bridge the gap in culturally adept care pathways for Black youth? Were there specific services that are experiencing increased wait times or gaps that could help address the needs and access issues?
So generally funding, as you many people in this audience probably know, for mental health is way below what the actual population need is and what the impact is on the population. So the number one question is like there needs to be parity in mental health funding and children's mental health. Children in the system, children and youth generally have the worst wait times, the poorest access to care, and just generally the funding is not there. So, I'm biased, of course, I'm a child and adolescent psychiatrist, but I really, really think we need to look at our funding very significantly at a provincial level, and we need to bring that up to where the need is because it is nowhere in the vicinity of the need. And then if we look at kind of what specific programs would be helpful. The things that I specifically advocate for when I'm asked this question is access to psychoeducational testing that is covered by the public system. Because for those who don't know, it costs about $3,000 to $5,000 to get psychoeducational testing done for your child. The wait times in the Toronto District School Board, because I work in Toronto, are 2 years plus. So if you have a child who's in like grade one, grade two, and they have significant learning problems, and they're not identified or supported until they're in grade five or six, if they even get on the list, which most kids don't, and most Black kids that I'm working with, especially in high priority neighborhoods, are not getting on those lists. Those kids then kind of fall into substance use, criminal justice, all of these things because their learning needs are not met. And if you have money, you can afford to pay for that psychological testing. But if you don't, which many people don't, then your child is just left by the wayside. So that one is a huge thing that I think we need to change. And then the other specific thing is trauma-based psychotherapy. So I specifically trained it in my residency because I'm an MD, and so my services are covered by OHIP, but you can only do so much. And there isn't really mandated trauma training. A lot of trauma services, again, are not OHIP covered. And if you think about something that I've also learned about working within various communities in Toronto, I should mention I work in the Jane Finch community, I work in Regent Park, and in addition to working at CAMH, and those communities just have so much trauma. Like there's so much trauma in those communities, gun violence, poverty, break-ins, vicarious trauma. And when I was doing my training, I was told by the community, like when I was talking to multiple communities, what do you think we should do? They said, we don't need more psychiatrists to prescribe medications. What we need is people to understand trauma and practice in a trauma-informed way. If you want to shift people's experience, you want to change things, that is like a really essential component.
Okay. Let's get in another question here. We'll go to this one. I would be very interested in hearing more about your findings about Francophone Black youth. And also, can you speak to how best to translate your work into areas with smaller Black populations where Black practitioners are fewer? For example, Northern Ontario. However, the community is growing rapidly up there. So, yeah, what are your thoughts on that?
I have to go back to look at the Black Francophone for more specific information. What I can tell you is that the pathways were worse and knowing how to navigate systems was more difficult because the community is smaller and there's fewer places to go for care. You also are probably seeing, and I think what we would say as well is there's an overrepresentation of people without status or people with immigration or migration issues who then have to like layer on that challenge with navigation. At least in Toronto, a large proportion of the Black Francophone community is either first or second generation migrants. And so there's also that immigration piece as well.
Okay.
In terms of the North, so I work in Nunavut now, and I have worked like in North Bay and across Northern Ontario. Um, when we talk about some of this work, I try to get away from the idea of really focusing on a specific population, but more an approach. So, who is not getting the services within your community? Can you find out what some of the reasons are that some people are not coming through the door? Are there lessons you can apply that are more universal? So, being interested, being curious, being mindful of police, that will really translate to a lot of racialized folks. And in the North, it will really translate to Indigenous and Black people. The curiosity and the treating someone as human and the unlearning your unconscious bias, again, that applies across populations and is something you can apply. And it doesn't have to be a service just for Black people. It can be a service for racialized people, or ideally, what we're all going towards is everyone can go anywhere and they will all get treated in really kind of affirming and thoughtful ways. It doesn't have to just be a service based on race or ethnicity. And then this is like a very specific point, but something that you may see and I see in the North is the lateral violence. It's just something to be aware of and mindful of and do some learning around. Specifically, Black Indigenous kind of violence and some of the resentment within community is something that I see quite often in the North and just also comes from a general approach to understanding more things about anti-racism, doing anti-racism training, understanding those complexities and those nuances, and really that like not knowing stance is a really good place to start and being noticing of your own like discomfort and that kind of stuff really gets you far.
Okay. Next question. What are your thoughts on the lack of culturally grounded programming for mental health for Black children and youth? And maybe another way to look at it is what do you think are the impacts, that lack of culturally specific mental health programming?
I think we have on our team Donna Alexander, who some of you may know, who's like, Donna has just been fighting for this for so long. And until 2020, there was really this idea of like, it doesn't matter, everyone's treated the same, we're colorblind, like all of that. And that just doesn't work. I just looked at some federal data looking at health disparities, and those health disparities haven't really changed. The populations that are still seeing the worst mental health outcomes haven't really changed. And if we don't put specific attention, so if we don't think about equity versus equality, like if we don't specifically target things to what people need, we don't actually undo or change the outcomes of the mental health disparities. So that's my argument for things that are specific and understanding versus like a one size fits all approach.
Okay. Okay. Now I'm noticing we have about 6 minutes left. We have a lot of excellent questions. Amy, would you be okay if we stayed maybe 5 extra minutes to try to get through as many as we can? We'll try to keep our answers a little bit shorter, but we'll go through because this is really an interesting discussion. So our next questioner says, excellent presentation. Agreed. Are there specific program supports that are being developed as a result of the study?
So this study, I think, is telling us we're going to try to take it back to some of the folks at CAMH and other people who do policy to talk about two populations, the two that I spoke about. So services for queer Black youth, like really looking at that and thinking about what do we need to do to better support youth. And then the other one is around psychosis. So on my list somewhere is to take that back to folks that are making some decisions around psychosis programming and planning, and to kind of share, this is what folks are saying and the community is saying. Is there like a place to leverage that in terms of better support for LGBTQ youth? I just finished another study which was looking at positive coping strategies for racialized queer youth. Um, Again, with the same principles, like what do people actually do? What do they leverage? What do they create to help them cope with stress and marginalization? So another thought is, can we pilot like a positive coping group for these young people as another research project and then advocate for funding? That's like the next potential plan.
Okay. Next question is there any discussion of the experiences of youth coming out of or involved in the child welfare system and mental health outcomes?
Yeah, that's a great question. Kids in the children's child welfare system are not like, we're just not doing a great job of supporting those kids. Um, in the literature, what we do see in Canada is that those are the kids that are really overrepresented, not just in the youth justice system, but in the youth justice system of kids that are chronic offenders, repeat offenders, and end up in seclusion. Those kids end up kind of being shuttled to juvenile justice, and then they end up having very negative experiences there. And that's the case for, I think that research is only done on kids in care. That didn't do it by race, because for a long time in Canada, we weren't disaggregating by race, but we do also know that there's an overrepresentation of Black and Indigenous kids within the child welfare system. So you can assume that that would mean that there's an overrepresentation of racialized kids that are having those experiences and being in justice versus in the general system. And the challenge, if kids end up in that pathway and they are pediatric juvenile justice involved, a lot of children's mental health programs will exclude any kid who has current or recent involvement in the juvenile justice system, which means, and then there is no real care, mental health care. There's very limited mental health care within juvenile justice settings. And so those kids are then set on that trajectory that means that they will really have a change in their options going forward.
Okay. Our next question is an interesting look at the small p politics of resource allocation within organizations that are already, strapped in terms of their resources. But the questioner says, community agencies are often very overwhelmed with the current services they are providing. Asking them to add culturally responsive care seems like another request that adds to their already full plate. So how can we advocate for more resources, a change in perspective on why they need to prioritize this work, and maybe a redistribution of their resources?
Excellent. And of course, like people in the community are doing incredible, important mental health work. That's where the mental health work happens. So I also do some training around anti-racism with different organizations. And what I say when I do that is it's not an addition. So specifically when we were trying to engage people in corrections, this is not an addition to your workload. It might feel that way, but what we're trying to do is make your work actually better. So if you're actually better able to understand somebody, if you're better able to get them into care earlier, it actually means that you're seeing people who are not as complex, not as sick, not as angry, not as frustrated, and you might also have some more satisfaction. So if somebody actually is enjoying their care, they really love their relationship, they're really engaged, they're really benefiting, there is so much good that comes out of that it goes against burnout, versus like being in that constant battle and feeling like you're not doing anything. That has its own kind of issues with burnout. So it's not even necessarily like making huge changes. It's just saying, hey, let's incorporate some of these principles, let's test it out, let's see how it goes. And of course I hear the positives, but when I hear it back from people, they say, oh yeah, I am seeing that it's less of a battle, and I'm feeling like a bit more movement, which helps me feel more engaged in my work.
Next question. Are there any existing frameworks out there developed by Black youth for mental health programming?
Excellent question. I don't know yet. There's one person you should look up. So the Pathways There's a Pathways project by the Black Health Alliance. Tianda Fante Coleman and Fatima Jackson Best did that. Tianda is actually a PhD student now, and they, did a lot of really excellent work in the community and thinking about frameworks. But then I have a graduate student named Rhonda Boateng. She's actually doing her master's thesis on looking up frameworks for culturally responsive care for Black youth with mental health difficulties. So stay tuned for her
Okay,
master's project.
we certainly will. Just a comment came in. That piece on lateral violence is so very true. Thank you. Very helpful when we were talking about the Northern Ontario, Northern Canada, and that lateral violence between communities, racialized communities. Next question. Do you see increased mental health illnesses among Black youth following legalization of marijuana? And how can Black youth be educated on the dangers of using marijuana? We can't sit and keep pretending that marijuana use is safe. And why is there overdiagnosis of Black youth with oppositional defiance disorder?
So the last point is an easier one to answer. Oppositional defiant disorder is a very behavioral diagnosis. It's not about anyone's inner experience. So all of the ways in which you make that diagnosis, there has been some change in DSM-5, but in DSM-4 and the way a lot of people use it is it's really about the behaviors. It's about not asking why. So if you look at behaviors, especially of a kid that's traumatized, or especially of a kid that's in an environment that's not meeting their needs, a lot of their behaviors are going to be looked at as oppositional. And if you don't ask the why, then you stay with oppositional. I really prefer to not diagnose ODD if I can help it, very much in a minority of cases, because again, there's no specific intervention for the young person. It's really for parenting. About marijuana legalization, I actually don't know if I know the data well enough on marijuana and psychosis to see if we can yet look at the patterns of psychosis rates following legalization. I have a colleague who works on that, and she may know that data a bit better. But what I do talk to young people about when it comes to marijuana, I did see a bit of a spike in use and especially high amounts of use after legalization, but that was during the COVID pandemic and lockdowns, and kids' substance use went like wild during that time. So it's hard to say. I have seen a lot of kids dial it back. What we talk about is, what does recreational use look like? The just say no approach doesn't work for kids. It never has. So something that we talk about a lot is, okay, if you're going to use, here are the real harms and here's how to mitigate them using lower potency THC products. CAMH's Youth Council put out like a lower harm reduction harm guideline for cannabis use. There are now some low risk cannabis use guidelines. So again, using that to speak to young people about their use and what the potential risks are and how to mitigate those risks and how to know when you're heading into problem territory, like smoking every single day, all day. I use the analogy of, it's like if you were to drink, alcohol is legal, but if you drank 10 drinks a day, that would be a problem and you couldn't stop. So that's also something that we do.
Excellent. I'm very pleased that we got through pretty much most of the questions. We had a couple of comments. Thanks so much. This was a wonderful presentation. More like this is much needed. I have noted that, our team has noted that. We're certainly going to look into doing more events like this because I agree it is needed. So let me first of all say thank you very much for your presentation, Amy. Fantastic. And as we wrap up today's PHO rounds, again, I'd like to formally thank Dr. Gajaria for presenting. And I'd also like to thank everyone who joined us for today, the excellent questions that kept coming in. Thank you so much for that. And lastly, to access past presentations and to view confirmed and upcoming sessions, please visit the PHO website, head to the Education and Events tab or page and click on Presentation. So on behalf of Public Health Ontario, I want to thank you and wish you all a wonderful day.